Yeah. Yeah, that's a good idea. So I'll post both of those after the quiz, because I don't want you to get, because if you get the, what I'm trying to figure out is, will people watch the videos and be ready for, that's really what and I did this a couple years ago, and a long time ago when we first were here. And when I did the quiz, there was virtually no difference, which may happen again, I don't know. But then I found out literally nobody watched the videos. So, yeah. I know, I usually do when I actually make them for teaching, but we're trying to recreate exactly what I said. I'm afraid that if I use my other videos, I might say different stuff that maybe gives somebody an advantage or disadvantage. You know what I'm saying? So you're right. I now do Khan Academy style, no longer than 10 minutes for each video. But okay. So thank you for your patience with this. I hope that it's recording. Today we're going to talk about dosage regimen design. And as we talk about, first of all, why study pharmacokinetics at all? Why would we study pharmacokinetics? I know you probably say, well, I'd rather not, right? Maybe some days. Why would we study pharmacokinetics? I'm not asking this. This is not rhetorical.
You're legitimately asking.
Yeah, why do we care? What? Study the effects of drugs. Pharmacokinetics is probably more about certainly the effects is part of it, but really what we're trying to do is make sure, right, that patients don't get less or more than what they need. We don't want them to suffer toxicity, but we want to ensure that what? That they're effective, right? If we're going to give them to them, we want to make sure that whatever dosing regimen we're giving to them of these drugs, that for that individual patient, it's effective but not toxic, right? That's really the goal, isn't it? At the end of the day. Now, we study a lot about kinetics in between because it helps us to understand major things about drugs, like could they have side effects, la la la, ba-da-da, okay? But the major big point is, let's try to make sure whatever we're giving them, that we're not hurting them, it's not toxic, and it's effective, right? So that's our goal. And because of that, we can predict a lot of things too, which is exciting. So we want to use what we know about the drug and the patient to make our best attempt at ensuring a patient's drug regimen is effective but not toxic. I know I added a few slides, but that's because I wanted to actually have you think about this. A lot of these slides are added because I didn't want to give them to you ahead of time, but I'll post these final ones too. Okay, so don't feel like you have to write everything down furiously. Okay, so how do we do this? The topic of the day, which is dosage regimen design. I feel like this piece of information that we're getting today is one of the most important pieces of information that you will have in this class. And it's foundational for the rest of the semester. Okay? So here we have a graph of a drug. Well, it's not of a drug yet. But here we have time in hours and concentration of drug in milligrams per liter. Here I've written what I've set 50 as our maximum concentration and 20 is our minimum concentration. I could do whatever I want. This is just me making a drug up, right? So what's our goal? Right, to be between those for our dosing regimen during the whole dosing regimen. That's our goal, right? Good. So here's our drug called Monday Morning. Right? Do you like this? It's in the therapeutic range, right? Our maximum. So what I look at right away is the curve generally where I want it to be? What's the answer? Yeah. Is the Cmax acceptable? Yeah. Is the C-min acceptable? Yes. So by looking at this graph, this looks lovely. Of course, I made it up, so I, on purpose made it that way, right? So what you want to see here, and that's what I look at, first of all, is the whole graph. Like, where is the whole curve? And then specifically at the max and min, okay? So this is Monday morning at steady state. Now, never, ever, ever, I'll always say this, or I'll try to remember to say it every time, but I want you to be thinking of it even if I don't say it. And that is, never look at this without looking at the patient, right? Because this C-max and C-min that has been set as your therapeutic range is a statistical number. So what I mean by that is, it means that most patients will fall in that, but maybe Jimmy's C-max is 40, right? So you don't want to look at it without looking at the patient, making sure the patient is showing signs of the drug being effective and not showing signs of toxicity, right? So never look at these numbers without looking at the patient. The problem is in this classroom, it's sometimes hard to look at the patient. I will sometimes give you data about the patient that will help you determine that, though, right? Or I may ask you, what do you want to know? So if this is an antibiotic, what might you want to know to see if it's effective? Right. Are their symptoms improving? So things like maybe temperature or maybe white blood cell count or things that are signs of the infection, right? What would you want to check for signs of toxicity? Well, you'd need to know the toxic side effects of the drug, wouldn't you? And then you'd look for that. Good. Now, when I say that we look at that, where the whole curve is placed, what we usually look at there is called the CSS average. The CSS average, does anybody know what the CSS average is? It's at steady state, yep. It's the average concentration at steady state, exactly what it's named. But students will sometimes falsely think that it's the average between the peak and the trough. It is not that. The way you get the CSS average is to take the area under the curve. You all know what the area under the curve is, right? At steady state. And you divide it by the tau. So it's kind of like the average concentration that happens over that dosing period. Okay? So this is important because we're going to be talking about CSS average a lot. We often will target the CSS average because that really tells us basically where the whole curve is, doesn't it? If our CSS is higher than what it is there, which is about 35, the whole curve is going to be shifted up, isn't it? And if the CSS average is lower than that, the whole curve is going to be shifted down, which in either case probably wouldn't be okay, right? So CSS average gives us a snapshot of where the whole curve lives. And we often use it for targeting, and I wanted to make sure I defined that and showed that to you before we get into the next steps. Is everybody with me so far? All right, so what are our